Hey, folks, welcome back to the Second Opinion podcast with Dr. Paul Kolodzic. I'm Terry O'Brien, your producer. Joining us remotely is both Dr. Paul and Danielle, who's at her new school down in Georgia. Say hello, Dr. Paul.
Hello, everybody.
All right, Danielle, how are things in your new school down in Georgia?
Things are great. Yeah, I love it down here.
And you're going for your master's degree in entertainment production, something like that?
Business, creative business leadership.
Okay, well, welcome back, Danielle. You look great remote. Um, Dr.
So we've often reminded Danielle when she goes on to have this huge career as in production and creative arts that she remembers us. I hope you will remember us, Danielle, and how we were involved in your formative years.
Formative years.
Absolutely. Formative years. Absolutely.
All right, so Dr. Ball, we've done a few podcasts on this topic, but it seems like it's really picking up steam, and we want to dive into a little bit more, which is the studies show that the use of GLP-1s can help people who are struggling a little bit with alcohol use. Do you want to kind of go a little bit deeper into that, or take this in a different angle? What do you want to do?
Yeah, I thought we would do a podcast here with just some background information on this topic of alcohol abuse. What are the numbers? What's the best approach to treatment? How do you define alcohol abuse? So, a little bit of a background on this one, and then we can touch on the GLP-1 stuff, and then get into it in more detail in a later podcast. But the GLP-1s are now being used by major rehab centers for reducing alcohol use. And so this is coming. Based on my personal experience, because I had one foot in the metabolic health world and have one foot in the addiction medicine world. I think this is going to be the treatment of the future for alcohol use disorder. So I thought we'd do a little bit of background on that topic, and then touch on the GLP-1 effectiveness for the treatment of alcohol use disorder.
So, how did you first find out about it? Well, I mean, what brought this to your radar? How did it come
Quite
across?
quite honestly, serendipity of treating my obesity patients with GLP-1s, and seeing that these patients come back and volunteered to me wasn't even on my radar screen, but come back and volunteered to me that they're drinking much, much less. And the word they used was disinterested. I used to go home and drink half a bottle of wine a night, and now after a half a glass, I become disinterested in finishing it. And I think this is what happened with a lot of clinicians across the country, which has now generated some specific studies on this topic, which could eventually lead to FDA approval for this indication.
So what's happening with people that are on GLP-1s for weight loss, and then you say they become disinterested in alcohol? What's happening? Is it something chemical, mental, all of the above?
So again, the mechanism of actions of GLP-1s are they slow gastric emptying, they lower blood sugar, and then they have the direct hypothalamic effect on the brain and your hypothalamus, which is the hunger center of the brain. And I think it's that third effect that impacts people. They want to eat less, they want to drink, they drink less as well. And sometimes without any effort. And now in some of my patients, I'm specifically using GLP-1s, even in patients, this is off-label use, not FDA approved, even in patients that don't meet BMI or diabetic criteria. And when you put these medications into a comprehensive program that includes some behavioral approaches, the results really can be remarkable. Hey, can we back up a little bit and talk about, what is alcohol use disorder? What is the definition of too much drinking, et cetera? And then I'd like to get into this concept of harm reduction versus abstinence, which is not necessarily people basically going cold turkey and never drinking again, but people seeking to reduce the amount of alcohol they use, because that's the majority of my patient population.
All right,
Is
so
that okay?
again, tell me what is considered the right amount to drink, right? I don't know what that
Okay.
is.
Okay. Excuse me, technical issue there.
That's all right.
Um, uh, so There are a couple different definitions. So, the usual way to diagnose alcohol use disorder, and that's the terms used now. Alcoholic isn't really a term that is used clinically anymore. It's kind of seen as a negative term. So the term is alcohol use disorder. And you go through a checklist of about 12 items that define if there is an issue. And these are items such as, are you drinking more than you want to be drinking? Has your alcohol use caused relationship issues? Have you missed work or other obligations? Have you put yourself in a dangerous situation with your alcohol use? Have you given up things you enjoy doing because of your alcohol use? So this is a scoring system, and you can get to mild, moderate, and significant alcohol use. Now, the CDC has absolute objective indications, and that is more than 15 drinks a week for a male and 7 drinks a week for a female, which
Wow.
is, completely unfair to the women, but it's the way it is just based on physiology and how women process alcohol and the fact that they're generally smaller people. Um,
Now,
and then
does that mean, real quick, does that mean if I don't drink Monday through Friday, or Sunday through Friday, and I have 7 drinks on Saturday, I'm good?
you just teed me up because the next
Wow.
words out of my mouth were going to be, there's a sub definition of binge drinking disorder, and that's generally more than 4 drinks in any one day or one sitting.
They really got you boxed
So
in here, don't they? They don't let you, they got
well,
everything.
I've spent 35 years in the emergency department and just seeing the bad effects of alcohol use. I've had even patients that seen the same patients when I worked in the same emergency department over 20 years, and really them going from, a young adult abusing alcohol to a middle-aged person dying of cirrhosis.
But what do they come in
So,
with? I mean, if somebody's coming to the ER with an alcohol related topic, what is that? Are they just drunk? Are there something else going on that's causing an ER issue?
well, as alcohol abuse progresses, it can cause all kinds of health issues, gastrointestinal issues, bleeding, obviously liver issues, cirrhosis, long-term dementia issues. It can have a direct cardiac effect. So there are all these different issues. But, a lot of times when we see them in the emergency departments, it's in the acute situation of they're intoxicated, their family is tired of it or disowned them, and they're seeking help for that purpose. And that's one reason for my interest in this area, because the traditional approach to alcohol management has been abstinence. It's basically you drink or you don't drink. And when you get to an inpatient situation, people get admitted to the hospital because alcohol withdrawal can be very, very serious, very, very life-threatening. um, Abstinence initially is the appropriate approach. And for people that want to pursue abstinence, I think that's great. But unfortunately, there is that subcategory of people that pursue abstinence that get on this, merry-go-round of abstinence relapse, abstinence relapse, abstinence relapse. And, the rehab industry focuses on residential treatment, which means you go to Malibu and you ride horses and sit on the beach, and you're in this completely controlled environment, and you're abstinent, and that's all great. And then you get back to the real world with the stresses of family and work, etc., and that relapse often occurs. So, in the inpatient, not the residential stuff is very, very expensive, and so it's become an industry in that regard. So my approach really in treating people with alcohol use disorder is a more pragmatic approach. That's an indication of my patient population, which is, let's reduce your alcohol use. You're drinking more than you want to drink. Let's reduce your alcohol use. And then if you want to go on to abstinence, that's great. But, in a normal outpatient setting where a patient comes to see me, every, 3 to 4 weeks, and we're prescribing medicines to help them decrease alcohol cravings. Let's set targets for reducing your alcohol use. And that is a contrasting approach called harm reduction. So, harm reduction again is contrasted to abstinence, where you're looking at reducing the amount of alcohol you're using. And there are plenty of groups out there behaviorally that support that. Smart recovery is one of them, where people participate in that, and it's not necessarily the traditional Alcoholics Anonymous 12-step program. It is a harm reduction program where we talk about how you're going to manage your alcohol use at a lower level. And the majority of patients that come to me that want to reduce alcohol use, quite honestly, most of them do not want to be abstinent. They just feel that their drinking has progressed to a point where they're concerned about their health. They aren't as sharp at work because they're drinking in the evening, maybe binging on weekends, and they're interested in harm reduction. And that's what I've seen great progress at people significantly reducing their alcohol use using medications such as GLP-1s.
And you had mentioned patients may come back 3 to 4 times to work on this harm reduction. And is that different for every person? I mean, some people it takes 6 months to a year for them to manage that, or is this something you have to be on the medication for the rest of your life to maintain a lower amount of alcohol use?
Yeah, so we're early in the game on this, to tell you the truth, because GLP-1s really are just being used for alcohol very, very recently. Again, I got to mention, not FDA approved, but there are a lot of treatments out there in medicine that are not that are used for an indication other than what they're FDA approved for. Um, but it's variable. I've had patients come to me literally that, are drinking 25 to 30 drinks a day. And they
Hey.
want to get that down a day.
Wow.
Yeah. Yeah. I had a patient that was going through a divorce, and he would come home from work and he would sit in his van out front, still living with his wife, and he didn't want to go in until she was in bed. And he would sit in his van and drink a case of beer or more.
Wow.
And then I've had other patients that, specifically, I had a doctor that was drinking about 12 drinks a week, and he felt that was way too much because he felt that was impairing his sharpness the next day with his patients. So he wanted to reduce. So different levels for different people. It's a work in progress, and that's why you have to tailor a treatment plan for individuals related to the specific medications you're going to use and the behavioral approaches that you're going to use. But um,
The one,
but
one,
in my go ahead.
one question I have for you is I've recently seen, like, now I've seen the commercial 3 times where
Yeah,
there's an ad on TV, national TV,
yeah,
where they talk about this topic and the use of some medication. They don't say what it
yeah,
is. They had a name for it, right? But they say if you're out drinking, you feel it's out of control, reach out to us. We're able to help you, blah, blah,
right.
blah. It seems like maybe are they offering some type of pill form of this? You think?
Yeah, no, not a pill form of a GLP-1, but let's go through the medications that are used for alcohol abuse. The FDA approved ones to start. There's an old medicine called antabuse. And this was the medicine where if you took it every morning and then you drank alcohol, it would make you sick as a dog.
Okay.
Nausea,
Hmm.
vomiting. So that's I haven't seen. I've maybe seen a handful of patients on that in the last 10 years. Is kind of a punitive approach to alcohol use. And of course, people got to take the medicine in the morning for it to work. I've never prescribed antabuse. There's another one called acamprosate or Camprol, Campral. And that is a medicine that provides some moderate reduction in alcohol cravings. The problem with acamprosate and Camprol is that you got to take 2 pills 3 times a day, and the compliance is just somewhat limited.
Yeah.
And then the medicine you just mentioned that there are advertisements on TV about is naltrexone, and that's a medication I have used for the last 8 years to help people with alcohol. So
And it works.
naltrexone, it is helpful. Yeah, it works. I've had significant reductions in alcohol use using naltrexone. I use it rather than taking a pill every day. I use it a specific technique called the Sinclair method, which is on days you drink, take the medicine. It mutes the response to alcohol, some of the pleasurable feelings from alcohol. On days you don't drink, you don't take it. Go do something enjoyable, walk the dog, work out, let your dopamine and serotonin receptors run wild because they are not blocked by the medicine on those days. And your brain kind of learns over time that you can, have positive days, good feelings without alcohol. So I've used naltrexone for years with the Sinclair method, and it has been very effective. And now there is the opportunity to combine, because they have different mechanisms of action, the use of naltrexone with the GLP-1s. And I think that's going to be the killer approach to reducing alcohol use for people. Again, harm reduction may be first, then followed by abstinence if people choose abstinence. As I mentioned, there are some major centers now in this country that are using GLP-1s routinely, often in combination with naltrexone, to reduce alcohol cravings. And these are situations where it's not only a harm reduction approach, but in some residential facilities where it's an abstinence approach. So this is really, I think a great opportunity in this area. And as I think I mentioned before, AA and abstinence is great for people that want to pursue that. And I'm very, very supportive of that for my patients that want to go there, but there need to be alternatives as well. And AA started in 1935, and really that approach has been unchanged in terms of the treatment for alcohol use disorder. But we don't treat heart disease and we don't treat cancer the same way we treated it in 1935. And so I think these alternatives, which may be a better fit for many people, should be considered. And so that's what I'm doing in my practice now, kind of taking the leap with appropriate consents, people understanding that this is not FDA approved for this purpose. Mostly people that want to reduce their alcohol use, not necessarily eliminate alcohol use. And we get them started usually on a combination of naltrexone using the Sinclair method, and then low dose GLP-1s, and couple that with appropriate behavioral guidance. Everybody's asked to keep a drink log. You got to tabulate the number of drinks you're having every day. We set goals, this many drinks per week, no more than this many drinks in one setting. It's like continuous quality improvement. You kind of work your way down the line. You set a goal, you reach that goal, and then you set another goal. And finally, we get people where they want to be, whether that's a significant reduction in their alcohol use or whether that is abstinence.
So as we land this podcast, because we're about out of time, I would like to come back maybe on another podcast and talk about when you say 14 drinks or 7 drinks for females. I mean, a beer is different than a gin and tonic from
Yeah.
an impact. So I want to cover that on a separate podcast because I think we could go into that a little bit.
Okay.
Any last words of wisdom before we go?
Are you telling me your beers are 21 ounces of 14% alcohol, Terry?
I'm telling you, I don't drink at all. A matter of fact, I haven't. I drank once or twice in high school, and then I realized I don't like being out of control. I'm a control freak, so I need to be in control at all times, and that's why I'm landing this podcast. Danielle, we want to wish you well down in Georgia there at your new school, and we'll have you back on a podcast when we do them remote like this.
It sounds good.
All right, guys.
Terry, you gonna plug things? You just gonna
To
leave
be
us
honest
with
with you,
that?
the website's changing. Things are changing. I'm not exactly sure what to be plugging, what not to be plugging, but we should talk about how your website is going to be drpaulkolodzic.com, and everything's going to be merged to that, from metabolic health to
Right. Just
CGMs to alcohol use through GLP-1s, the whole 9 yards.
right. So if people are interested, it's DRPAULKOLODZIK, Dr. Paul Kolodzic.com. And then there's information on these different areas now as we start to focus more on GLP-1 and naltrexone for alcohol use, but still providing background information on metabolic health and the use of CGMs, et cetera.
And if you guys are looking for a great Christmas gift for somebody who's just dying to know more about CGMs, your book, about CGMs is available on Amazon, correct? Best-selling book on CGMs.
Selling book. Still, even though it's been out a year and a half or so now, it's still doing really well.
All right, so now we're going to land this podcast again as a control freak. Thank you for joining us. We'll see y'all again real soon, or hear y'all again real soon. And that's it. Say so long, Dr. Paul.
All right. So long, Dr. Paul.
Say so long, Danielle.
So long.
All right, guys, see ya.
Bye.